Bismillahirrahmanirrahim. Qalu subhanaka la ilma lana illa ma 'allamtana innaka antal alimul hakim. We have covered almost respiratory system and indications, maintenance, and indications for intubation so far. Now today we'll be discussing about how to take the patient off the ventilator. Before that, the major part of this lecture will be covering what are the difficulties of discontinuation of ventilatory support. Now, in other words, we call it weaning also, weaning the patient off the ventilator. Weaning means discontinuing the mechanical ventilation. So in strict sense, it's a weaning refers to a slow decrease in the amount of ventilator support with the patient gradually assuming a greater proportion of overall ventilation. So there are different ways of presentation. Basically, there are three things which we look at before we start our weaning, before we start taking the patient off the ventilator. First thing is adequacy of pulmonary gas exchange, whether we have achieved our target. Now the blood gases are adequate to take the patient off the ventilator or not. Second is performance of respiratory muscle pump. How good is the respiratory muscle pump of the patient? So it's not easy to switch the ventilator off and ask the patient, now you go on taking a deep breath. But we have to look at the efficiency of respiratory muscle pump of the patient. Then third is psychological factors also. These are very important to consider because these patients have been on sedatives and some of the patients need large amount of sedatives and some people need just a touch of sedatives. And outcome we should do the post ICU clinics also, as it is being done in most of the European countries. Once the patient is discharged, then they are called back to attend the outpatients by the intensivist to assess whether the patient has got some psychological effect left or not, and then to look after that. Now, adequacy of pulmonary gas exchange means there must be, when we are taking the patient off the ventilator, whether the patient is going into hypoventilation or not, or whether the patient is maintaining the required level of ventilation. That we have to assess. Second thing is whether there is going to be some impaired pulmonary gas exchange or not. It means we will have to look at the blood gases also and whether they are fulfilling our criteria or not. Third thing is we have to look at this, whether there is decreased oxygen content of venous blood. That we will have to look at the partial pressure of oxygen in arterial blood and oxygen content of the arterial blood and venous blood also. Then we have to, before we do the content, we will have to look at the hemoglobin level also, because the bulk of oxygen is carried by the hemoglobin. Now, saturation does have importance because under the saturation is hemoglobin, total hemoglobin is more important than only looking at the SpO2. So you should know the SpO2, but you should know the total amount of hemoglobin because the bulk of oxygen is attached with the hemoglobin. So then we can calculate the content of oxygen. It means we'll have to calculate the DO2 and then VO2. Now, respiratory muscle performance, we'll have to look at the neuromuscular capacity. Patient has been on ventilator, he has not been using his muscles up till now, and the muscles have been resting. We'll have to recruit the muscles also. Now, the muscle performance depends on the respiratory center output, that how good is the respiratory center, whether they are getting the messages from respiratory center to breathe in and breathe out. And second thing important is the phrenic nerve dysfunction, particularly those patients who have been on chest surgery or on CABG. So, because there is likelihood of damage to the phrenic nerve, the likelihood of small injury to the phrenic nerve, there could be likely to have some problem on the diaphragm as well. Then third thing is the respiratory muscle strength and endurance. Is there anything which is affecting the respiratory muscle strength? Even if the respiratory muscles are normal, hyperinflation of the chest, if we are ventilating the patient with a large volume of gases, or there are large volumes of gases are being trapped in the lung at the end of expiration, that will have an impact on the outcome on the weaning also. Then chest wall motion abnormalities, could be paradoxical breathing, or if there is any chest problem also with the patient who cannot breathe properly with it, then we'll have to consider alternative ways to improve it when we are taking the patient off the ventilator. Then oxygen supply. We'll have to give the adequate oxygen supply. Then malnutrition, because any patient who comes to ICU, once the patient is water and electrolyte balance, then once the patient is in acid-base balance, then we try to bring the patient into nutritional balance. So if we don't look after the nutrition, it takes usually about 24 to 72 hours before we start our nutrition. So malnutrition is a very important contributor towards weaning. And then respiratory acidosis. If the patient is in respiratory acidosis, it will have a very bad effect in the weaning. It will not only affect the respiratory center, it will also affect the circulation also, because acidosis will depress the myocardium, and when the myocardium is depressed, stroke volume is reduced. When the stroke volume is reduced, blood pressure will be reduced. When the blood pressure is reduced, oxygen supply to all the cells of the body will be reduced also, automatically. Then metabolic abnormalities, again, the metabolic acidosis, metabolic alkalosis. So patient should be in the normal pH. Then endocrinology, and we'll have to look at the endocrine function as well. Then drug-induced abnormalities. We have been on polypharmacy. We'll have to look at that whether this polypharmacy is going to affect the respiration or not. So we should let the drug get out of the body if they have got some effect on the respiratory system. Then disease muscle atrophy. Now, if these patients have been on muscle relaxant, and when they were given the muscle relaxant, so disuse muscular atrophy takes place once the patient remains on the ventilator for a longer period. So that we'll have to consider. It means we'll have to start the recruitment of the muscle to coming towards the normal activity. Then respiratory muscle fatigue. So these are all factors which we have to consider before we decide that we are going to take the patient off the ventilator. Now, then respiratory muscle pump load. The patient might be needing the ventilatory requirement, increased ventilatory requirement. Patient might be producing too much carbon dioxide, or patient might be being ventilated on the dead space. The patient has got a lung problem, and the patient, we are ventilating the dead space more than the actual respiratory unit of the lung. Then inappropriately increase respiratory drive. The patient is breathing very fast, so that is almost dead space ventilation. So actually the amount of gases are not going into the respiratory unit, which is beyond the 16th unit of the lung. That's from respiratory bronchiole downwards. And then we have to look at the work of breathing also. So all these there are so many factors which you have to consider before we decide, now let's take the patient off the ventilator. Even if the patient is awake, asking you to take the ventilator off, it doesn't mean that we should take the patient off the ventilator. We'll have to consider all these parameters. Respiratory center output, whether it is a normal or it's being depressed. It's being depressed by respiratory acidosis, and there are some indices of drive, that is airway occlusion pressure at 0.1 second. You occlude the airway during inspiration, and ask the patient to take deep breath. How much negative pressure patient can create? That's called P001 or P1 second. So it should be around about -20 to -30 centimeter of water. It means the muscle power is adequate. Now the patient is ready to be weaned off the ventilator. Then mean inspiratory flow, that is VT over time, that how much is the tidal volume per unit of a time that gives us the idea that muscles are adequate, and now the respiratory center is doing well, and now the patient is ready to be weaned off the ventilator. Then carbon dioxide recruitment threshold. If we have been washing out the carbon dioxide too much, normal carbon dioxide is PaCO2, 40. So if it is less, it is bound to depress the respiratory center. So we'll have to bring the carbon dioxide near to normal level before we start weaning the patient off the ventilator. Suppose the patient's PaCO2 is about 25 or 30. So that will depress the respiratory center. To make the respiratory center to be effective, it should be near to 40. That's why the nature has kept PaCO2 around about 40. So it's 40 is the normal. Normality has got always significance. Abnormality will affect the normality, physiological normality. For example, the patient has undergone coronary bypass operation. Their phrenic nerve is likely to be damaged when they are doing bypass operation because hypothermic injury. They put the ice on it to make the heart still. They use other things also, potassium infusion into that, and then the ice cold water is infused there also to make the heart quiet. So it will be touching the phrenic diaphragm also. So it can affect the phrenic nerve as well as the surface of diaphragm. Then inadvertent sectioning. Sometimes if the surgeon becomes emotional or if it is a difficult operation, they might cut the phrenic nerve also. So that one has to see. Then stretching and compression of the nerve. So during operation, they are putting the retractors and they might stretch the nerve also. That will be mild injury. Then blood flow to the vasorum of nerve. There is blood supply to the nerve fibers itself also. So if those vessels which are very microscopic vessels which are supplying the nerve, so that might be damaged. So all these factors combined can affect the efficiency of phrenic nerve. It means it will affect the efficiency of diaphragm. So these things that we have to consider when we are starting to think that we should take the patient off the ventilator. Then respiratory muscle function, hyperinflation. As I told you, if there is hyperinflation, you are giving large amount of volume into the lung, or there is a large amount which is trapped into the lung and keeps the alveoli distended. So that will have effect on the recovery also. So especially diaphragm becomes flattened. Now normally diaphragm is like this, dome is going up on the both sides. If they become flattened, if you know the Laplace law, P is equal to 2T over R. So if the diaphragm becomes flattened, it means the diameter is increased. Pressure which is developed is called 2T over R. If radius bigger, the pressure developed for its function will be reduced. Or you will have to create large amount of pressure to make it functional also. So that's very important, because the diaphragm should not be flattened, dome should be like this, so that it should have effective contractility. Then the different fibers, if the fibers are horizontal or medially oriented fibers, so they will affect the efficiency of diaphragm. Now, abnormal in chest wall movements, asynchrony, paradox. If the abdomen and the chest are not in synchrony, then it's bound to affect the weaning. Normally, when you breathe in, what happens to your abdomen? Does it go inside or comes out? When you breathe in, so diaphragm, your abdominal wall goes in or comes out. Think about it, right? Then oxy supply. Oxy supply to the body depends on the cardiac output. Also, one of the factors is cardiac output. And if the patient is on ventilator and we don't think about the cardiac output, it means we are not going to assess the patient properly. So cardiac output should be adequate. If the cardiac output has been less, it means less blood is going to the tissue. When less blood is going to the tissue, less oxygen is going to the tissues. So that's bound to cause relative hypoxemia. Then oxygen content also. That depends on hypoxemia and anemia both. So then increase oxygen extraction. For example, in sepsis, hyperthyroidism. So even if you are given the normal amount of oxygen, but the oxygen requirement is more. So if the oxygen requirement is more, then relatively you are creating hypoxemia, relative lack of oxygen in the tissues. Now, even if you give a normal amount of oxygen, if it is extracted more in some of the tissues, and some of the tissues it is not extracted more, so it is going to affect relatively some parts of the body also. Now, left ventricular ejection also, that's very important also, left at the end of diastole, left ventricular ejection. So that's also important. And acute respiratory acidosis. If the patient has gone into acute respiratory acidosis, it means there is CO2 level is high. It means the pH is down. That's bound to affect the contractility of the myocardium. It will depress the contractility of the myocardium. It means it will depress the stroke volume. When the stroke volume is reduced, so cardiac output is reduced. When the cardiac output is reduced, blood pressure will be dropped. Then decrease endurance time. Now you want to ask the patient to let the patient breathe, then how long the patient can breathe properly. So this is the acute respiratory acidosis can affect the tolerability of a person for spontaneous breathing. So these factors we have to keep in mind before we decide that the patient should be weaned off the ventilator. Now, metabolic abnormalities, these should be corrected before we start weaning. Hypokalemia, hypophosphatemia. Hypokalemia, it will affect the metabolic electrolyte imbalance, and this hypokalemia also acts like acetylcholine. Always remember it. Even low potassium level will have a muscle relaxant effect. High potassium will also have a muscle relaxant effect. If low potassium, it means it will antagonize the effect of, it will reduce the effectiveness of the acetylcholine also. It means it will have a non-depolarizing type of muscle relaxant effect. When you increase the potassium, it will have enhance the depolarizing type of muscle relaxant effect also. Then hypophosphatemia, hypercalcemia, hypomagnesemia, these all should be corrected before we decide the patient should be taken off the ventilator. Then endocrine disturbance, hyperthyroidism, hypothyroidism, corticosteroid therapy. All these things should be looked into, right? They should be corrected as far as possible. Then respiratory system muscle pump load. Now this ventilatory requirement increases when it increases with the carbon dioxide, increased carbon dioxide production, increased dead space ventilation, and dead space and ventilation ratio is increased. It means you will have more dead space where the gases are not coming in contact with the blood than the spaces where the blood and the gases come in contact with each other. Normally it is 30%. 30% of anatomical dead space and 60% of 70% is, or 66 to 70% is the space where the blood gases come into contact with each other. So if it increases up to 0.6, it's very significant. Then you should never ever try to take the patient off the ventilator. Try to correct the dead space effect first. You calculate according to the dead space equation. Then two things which are very important. One is the compliance and other is the resistance. If the compliance is reduced and resistance increased, that will increase the work of breathing. So that will increase the load of work which respiratory system has to bear. So that has to be normalized. That has to be brought, that has to be looked into it. The compliance should be as near to the normal as possible. Resistance should be as minimum as possible. This resistance could be because of lung tissue itself, could be because of conductive pathway, could be due to because of circuits you are you are using for ventilation. So all these things we'll have to look into it. So this is product of compliance and resistance called time constant, and the time constant has to be looked into it. Then psychological effect. Patient is on controlled mechanical ventilation. If the patient is awake, patient on ventilator does not mean the patient is sleeping or patient is unconscious all the time. It depends on the actual pathology for which we have put the patient on ventilator. If the patient is conscious, he will feel insecure. He will be anxious. He will have fear of unknown. Then he might be in agony. You have put the tube into the trachea, he cannot speak. He cannot express his feelings. So this is you people who will have to assess this thing. Then patient might panic also. Sometimes we have put the patient on ventilator and the patient is in panic and trying to pull everything out. So these all have a psychological effect, so we'll have to use antipsychotic drugs with it. That we should keep them quiet and they should not be. Sometimes I usually plug the ears also, because the hearing is the last sensation to go. So when he was on ventilator, I used to go and sit with him and I used to tell him, I have come to learn from you and you are lying here on ventilator. You will have to come back. When he came back, he said two things were bothering me. One thing is, he said, the noise of the door, when they were opening the door, the old-fashioned doors, these wooden doors, that was too much that it used to hurt me. And secondly, somebody used to come and say, you have to come back. When I told him that it was me, then he became my friend and he taught me respiratory system in a mathematical way. And he is still alive, he is about 97. So these things, minor things, make a lot of contribution once you are on the ventilator. The hearing sensation is the last sensation to go. Even if you have anesthetized the patient, I used to plug the ears with a cotton buds. And even if the patient is on ventilator, one should be very careful, give them heavy sedation, or you plug the ears also at the same time. So then he wrote a book, my professor, he wrote a book on sedation in ICU. And that is worth reading book. Then objective predictive indices. There are so many other also. Why? Because we should not be subjective, we should be objective. Subjective means we say that this particular person is better in looking after the patient on a ventilator, or he is the better person who can manage it in a better way, or he is the person who knows more about ventilation. No, there should be protocol and guideline, and we should strictly follow to it. And everybody is replaceable. Everybody should be replaceable. Nobody should be irreplaceable. Avoid unnecessary prolongation. When we put the patient on a ventilator, we should have an objective that we have to bring back as soon as possible. So shorter the period on the ventilator, the good will be the recovery. Longer the period for which the patient is on ventilator, then it will be gradually more and more difficult to wean them off. Right? Then identify the failed trial. If you have tried to wean the patient, if you have failed into it, then you document it and try it again in a different way. There are so many ways of taking the patient off the ventilator. It is not a mathematical way that if one patient has improved, has come out of ventilator, the other person will come out of the ventilator in the same way. There are so many alternatives you have to try, one by one, and then till you will succeed. Prevent premature weaning. Now, you should be, all these things which I have mentioned, you should go through that and don't try to wean the patient off the ventilator prematurely. You should be 100% sure now the patient can be weaned off and it will be successful weaning. Then suggest alteration in the management. Always in the morning round or whenever you are looking after the patient 24 hourly and hourly management, and then you should have alternatives also. If I'm trying this one, if it fails, I'll try another one. So give it time and go on trying. Don't unsuccessful weaning is more dangerous than not taking the patient off the ventilator. It can damage the patient more. Now, predictive variables, gas exchange. This is the most important predictive variable. Look at the PaO2, partial pressure of oxygen. It should be greater than 60 if the patient is having 35% of FiO2. On 35% of FiO2 should have greater than 60 millimeter mercury or torr. 1 millimeter mercury is equal to 1 torr. Then look at the AA gradient, partial pressure of oxygen in the alveoli minus partial pressure of oxygen in the arterial blood, and that should be less than 350, right? Then do you take the ratio, PaO2 over FiO2 ratio? It should be greater than 200. And then PO2 over P big AO2, that is the ratio. It should be 0.97 or 97%. So all through the blood gases, you assess this thing that it has to be brought within this range. Then you try your weaning. Then ventilation pump, vital capacity. It should be greater than 10 to 15 milliliter per kilogram. How much is normal? Normal is 35 to 40 mil per kilogram is your vital capacity. So it should definitely be greater than 10 to 15 mil before you decide to take the patient off the ventilator. Maximum inspirative pressure. Maximum inspirative pressure which the patient can create, and you put your finger on the tube and say how much the negative pressure patient can create. It should be around about minus 30 centimeter of water. So you should have it, that will tell you the efficiency of muscle strength. Then minute volume should be less than 10 liters. Patient might be breathing, if the patient is breathing fast, so your minute volume can go to 20 liter, 30 liter, 40 liter. But once it has come below 10, then it becomes, you should be thinking that it will be easier to wean the patient off the ventilator. Then PO1, that is the pressure, occluding pressure. Then frequency over tidal volume ratio. That you take the respiratory rate of the patient divided by tidal volume, that ratio should be around about 100, 90 to 100. If it is greater than that, then you don't try to wean the patient off the ventilator. Then they do some other tests also. This is called crop index or integrative index. That I'll mention a little bit later. Now this ratio, frequency over tidal volume ratio, breaths per minute per liter, right? That is a unit for it. Attractive features, easy to measure. It's very independent of effort of the patient. It's accurate. It's rounded off, the value is round about 100. It should be round about 100. This should be round about 100. Then you say that it will be successful weaning. Now, these are some of the difficult ratios. These are used in experiment in the laboratories. So we don't routinely use these things, and nobody does, even in the Western countries also. Now, crop test is this dynamic compliance into P1 max and multiplied with the PaO2 over P big AO2 ratio divided by the respiratory rate. This is a crop index. Then there is integrative index also. And in the advanced centers where they were doing the research work, so they are using these two indexes. Physical examination is the most important. Careful physical examination. You look at the respiratory rate, whether it is elevated or not, bedside tidal volume, you measure it. Then clinical impression, workup breathing. You always stand on the foot end of the patient. Whenever you examine the respiratory system, always stand on the foot end of the patient and look at the patient. A patient should be around about 30 to 35 degree head up. You look, even if the breathing is normal, you look at the alien nasal moving. If the patient is using alien nasal, it means it is excessive muscle usage. It means the patient is distressed, patient is dyspneic. So that's very important observation. Then other accessory muscle use, suprasternal recession. So during inspiration, if this is sucked in, it means there is some obstruction. Then if intercostal spaces are sucked in, it means there is some problem with the muscles. So then paradoxical movement. When you breathe in, so abdomen moves out. When you breathe out, abdomen moves in, and the chest also moves in. So this is a paradoxical breathing. Paradoxical movement of the abdomen and chest. Then always use auscultation. Put your stethoscope on the chest. Every person who is working in ICU or who is looking after the patient, except ward boys and sweepers, they should have this stethoscope around their neck. And every patient should have a separate stethoscope, as we have got. हर एक साल लटक रही है कि नर्स के भी यहाँ होनी चाहिए, वो उसी पेशेंट पे यूज़ करे, फिर लटका दे, फिर दूसरे पेशेंट को देखना पड़ जाए उसको दूसरी यूज़ करे, ठीक है. सो यू शुड मेक योर हैबिट टू ऑस्कल्टेट द चेस्ट, राइट. देन यू लुक एट द डिस्निया लेवल. डिस्निया क्या है? व्हाट इज द डिस्निया? हाउ वुड यू डिफाइन डिस्निया? Difficulty in breathing. In other terms, when you become conscious of your breathing. Now you are breathing, you are not counting your breathing. Now आप इस तरह नहीं कह रहे कि अब मैं एक सांस ले लिया, अब दूसरा ले लूँ, फिर तीसरा ले लूँ. ऐसे करते हैं कभी? नहीं. When you become conscious of breathing, that you are breathing. So it means you are dyspneic. ठीक है? Dyspnea is when you become conscious of breathing. आगे फिर dyspnea index दूसरी चीज़ें निकालते हैं. Then mental status of the patient, blood pressure, heart rate, rhythm, and whether there is any cyanosis or not. Cyanosis क्या होता है? What is cyanosis? Cyanosis is due to what? Right. What are the different methods? I enumerated, I told about 10 different methods of weaning the patient off the ventilator. You might be remembering on my first lecture of ventilation. Then, in short, the old method was spontaneous breathing trial. SBT is called, the spontaneous breathing trial. And second is, then became intermittent mandatory ventilation, IMV. And then they modified it into SIMV, synchronized intermittent mandatory ventilation. So synchronized ventilator and a person who is on ventilator, they synchronize with each other. Right? Then pressure support ventilation. Could be only IPAP, could be BiPAP also, or only could be CPAP. Right? So this is a pressure support ventilation. Continuous positive airway support. You just give only support, positive support, and don't leave any pressure at the end of inspiration. Right? So that's different ways. So these are just to enumerate few. So you do first of all spontaneous breathing trial, then intermittent mandatory ventilation, SIMV, or then you do pressure support. Pressure support में BiPAP आ जाता है, IPAP and EPAP दो हैं उसमें. Bi means bi level. During inspiration you put a pressure. धक्का लगाते हैं उसको. क्योंकि pressure support आप start from 7, 10, 8, 9, 10, 20 ऊपर जा सकते हैं. उससे जब when the patient is breathing in, you push with the pressure, gases are pushed with the pressure or supported with the pressure, so you will have a required target volume. You should have a target that this should be 500 milliliter or 600 should be the target volume in this patient. So that support should be, we should go on increasing until we get our desired target volume. Then at the end of inspiration, we want to keep some positive pressure into the thorax so that it should increase the functional residual capacity. So it should leave some gases so that diffusion is going all the time. So it will keep the alveoli distended. So there will be better diffusion of gases. Right? Now this is a 5 minutes trial. First of all, when you go on the TP's trial, spontaneous breathing trial, FiO2 should be minimum 40%. Then duration should be increased gradually, and expiratory limb should be bigger than the inspiratory limb. Then flow should be twice than the minute volume. Then monitor the blood gases, because that's what we want to see, whether the patient is maintaining blood gases or not. Right? So it's a different way of doing it. Now, factors that may impair the respiratory system muscles strength in the critically ill patient. As I have already told, hypophosphatemia, hypomagnesemia, hypocalcemia, hypoxia, hypercarbia, acidosis, infection, muscle atrophy, and malnutrition. All these things has to be kept in mind before you take the patient off the ventilator or before you start your weaning. Now, factors increasing the load on the respiratory muscles in ICU, bronchoconstriction, right? If there is a spasm, so that will increase the resistance. When you increase the resistance, so that will affect the time constant, and that will make the weaning difficult. Then left ventricular failure, then hyperinflation of the chest, and expiratory pressure should be kept over there. Artificial airways, if you are using artificial airways like tracheostomy and other things, you will have to look into it. Then ventilatory circuit also. You will have to look what type of circuit you are using it, and what is the length of the circuit, and what is the compliance of the circuit also. Now, points to master. Every person should consider these points. These are the must when you are going to wean the patient off the ventilator. Hemodynamics of the patient, first of all, that should be within normal range. Then oxygenation status of the patient, that should be within the normal range. Oxygenation mean FiO2, PiO2, P big AO2, P small AO2. Then you look at the saturation SpO2. Then you look at the DO2. Then you look at the VO2. Then you look at how much is the percentage of extraction of oxygen, 24 to 25%. Then you look at the lactate. That will tell you about oxygenation status. By doing the blood gases on a good blood gas analyzer, you will see all these things are written there, and then you look into it and treat it. Then acid-base status should be normal. Systemic vascular resistance and pulmonary vascular resistance should be measured and should be kept near to the normal as possible. Time constant, it means you look at the compliance and the resistance offered by patient by looking at the loops also on your screen. It will give you a lot of information. And how to use different weaning modes also. That you have got a big list, and that you should know how to use different mode for weaning. Now those are the points to look at it, but you should know those points, analyze those points, find out the cause of disturbance of those points, then you should know the steps to treat those causes. It's not just enumerating those things. You go into depth of it, you look at all those parameters. If there is an abnormality, analyze it, then find out what is the causative factor, then you should know how to treat it. Then you are able to wean the patient off the ventilator. The reference books which I have been using whole of my life are these two books. If you want to actually understand the respiratory system and the ventilatory status of the patient, or ventilation, different way of ventilating a patient. Physiological basis of ventilatory support. It's quite big. It's written by John J. Marini and Slutsky. I've been very lucky to attending their lectures. In Brussels, every year, in third week of March, there is a World Federation of Society of Intensive Care meeting. And these big guns, they come and present their papers, and those papers come in the form of book after 10 years. So I used to go and attend it every year. For 20 years, continuously I've been going there. I knew the subject which came in the books 10 years afterwards. So I've got their book also quite big. It's the physiological basis of ventilatory support, and it will open up your mind. It makes you understand what the respiratory system is, why we are doing this, why we are doing this. And the second book is the respiratory failure. It's again, I have been Tobin. Tobin is a main person. He used to present difficult weaning. His lecture always used to be difficult weaning. Every year there is something new coming in it. And he has written this book. And this book is multiple choice question on respiratory failure. 990 questions. There is no question left on the respiratory failure, even putting the patient on ventilator and weaning the patient off the ventilator. There are questions and answer, question, answer. And if you read all the things before, then you read those questions, it will open up your mind, it will clear your mind, and you will be able to understand the respiratory system and pathology of respiratory system, and the methods we treat the pathology of respiratory system will make very easier for you. Okay, thank you very much.